Welcome to the last of the GI disorders video lectures. This one is going to discuss anal-rectal malformations. These malformations can range from an imperforate anus to a stenotic anus to anal atresia. And they are commonly associated with other congenital defects, and that can be congenital heart defect, tracheoesophageal atresia, spinal anomalies, and kidney problems. In addition to our physical assessment, we can diagnose it through radiology. So the top picture, when you look at it very closely, you can see that the anal opening is very stenotic, so it's very narrow, versus the picture on the bottom where there is a membrane that's going across the anus. There's no outlet here. And so when we're looking at these babies in the nursery, we used to always do rectal temps, and that way we could say, yep, this anus is open. We're not doing that anymore. So unless we see meconium come out of that bottom, all we say is that the anus is present. These are two pictures of degrees of anal agenesis, and the top one you can see where it looks like that anal opening is just up there. There's just this piece of skin that's there that, gee, if we could just open that up, we would have an anal sphincter. And sure enough, that's what we would do. But when you look at the bottom picture, whoa, there is no anal muscles. There's nothing that's there. What do you think we need to do about that? Just think about that while we go through another slide. And then even worse than that is a rectal atresia. So similar to the esophageal atresia, you see how the rectum is in two parts and they are not connected. So the sigmoid is coming down and it's supposed to join into the rectum, and it's like, nope, it's all closed up. So we'll talk primarily about the imperforate anus because it's far more common than the others. There's no anal opening, and you might see a little thin membrane, and there may actually be a small dimple. And if we were to try and put in a rectal tube or a thermometer, we wouldn't be able to get it in. So this baby does not pass its first stool, and the belly starts becoming distended because it's filling up with stool. So they essentially end up with a bowel obstruction, and Lord help us if we don't find this in the first 2 or 3 days of life, because as everything backs up, then the baby may start vomiting. They may have a fistula that's going to the perineum or through the urethra or through a vaginal opening if it's a girl. We don't want that to happen. We'd rather just have the imperforate anus and we're going to fix it. So physical exam, imaging studies, and then surgical correction is needed. If they have just a stenosis, then we do manual dilation. And so we have rectal dilators, so they're very small, and we start with the smallest one possible that can be inserted, leave it in there for a very short time, take that out, put in the next one. You are not going to be doing this, but you may be assisting by holding the baby. So that's the manual dilation for stenosis. But for the imperforate anus, these kids may end up, they're going to have a colostomy put in, and they're going to reconstruct an anus. They'll open it up and allow it to heal, and then they'll take down the colostomy. So we want to position these babies so that there's no pressure on their perineum, on the perineal sutures, and then really good perineal care when you're changing the diapers. And then we do not do rectal meds, and we do not do rectal temps on these kids. And that ends the GI problems.